here today with Dr. Elizabeth Hooper, who is a colleague that works in my office sometimes with me, and she is a metabolic surgeon. So let me tell you a little bit about her. She got her doctorate from the University of Oklahoma and then did her general surgery residency at Rush, very fancy, and then did a bariatric fellowship at Tufts, even fancier. And she practices with DFW Bariatrics here in the Dallas Metroplex, and she spends a couple days of her week in my office where we stamp out metabolic disease together. Welcome.
Thank you. Nice to be here.
It's a pleasure to have you. It's always a pleasure to work with you. And I've always wanted to have a session together where we can kind of suss out the role of medical therapy, the role of surgical therapy, kind of recognizing that this is a really deep topic and we could probably talk for hours about these details. But let's just start by kind of giving some people orientation. Um, so let's talk about bariatrics specifically in the context of diabetes. Um,
Okay.
is it true that a bariatric surgery can actually fully reverse or cure someone's diabetes?
It is actually true. And that's really where that name metabolic surgery comes from, because there's not any surgery that I'm doing on the pancreas organ that produces insulin that I'm changing. So it's really about the metabolic signals or the chemical or hormonal signals that we are affecting with the physical changes we're making in the stomach or the intestines. So to answer your question, the yes, we can fully reverse diabetes. I sometimes will describe it to patients as we've made it dormant or put it into remission to think about other chronic medical problems. So we can see the A1C normalize, but certainly over time, sometimes diabetes or elevation in blood sugar does come back.
Yeah. I have a number of videos on the channel that talk about, the ominous octet and how there's so many moving parts to different kinds of metabolic disease and how obesity it's not just a problem of willpower.
Right.
There's a whole lot happening there. And there's a reason why there are specialties and boards that are devoted just to this topic. Um, let's put it into context. So if somebody goes in for, I'll call it kind of the classic bariatric surgery, the bypass, the Roux-en-Y, and they're on insulin before they go to surgery, how fast do we see that insulin need dropping off?
It happens really quickly, and that's where that metabolic change is happening. So, as the chemical signals change rapidly after surgery, when we're skipping the first part of the small intestine and bypassing the duodenum or the first part of the intestine, we can see those signals change that lead to decreased insulin resistance, increased utilization of the insulin your body makes. And oftentimes, people are also on a very specific diet, so very low carbohydrate. So, the combination of all of those things, most of the time when I'm sending someone home 1 or 2 days after robotic, minimally invasive bariatric surgery, they are going home on no insulin with very close follow up and monitoring their blood sugars, or a dramatically reduced dose. We might do a quarter of their normal insulin. Um, my personal practice is that I usually let people run a little bit high those first few days so that the stress of uh, the stress of surgery really dissipates and we can really see where they're kind of settling out, and then make adjustments and add some insulin back in as needed.
I think that's reasonable. And you mentioned minimally invasive. Is it standard now that all of these surgeries are robotic and not open?
Definitely standard to be minimally invasive, meaning small incisions. The classic example for that would be like how people have their gallbladder removed almost always. My approach is to use the Da Vinci robotic instrument so that I have 3D vision. The tip of the instrument is like your wrist. So when you move the instrument on the inside, it's me doing this on the outside, and that gives me a lot of um, dexterity and precision when doing those cases.
Yeah, it's so cool. I went to a session that your practice hosted, what, like a couple years ago, maybe now, and they brought the machines out for us to actually look at and lay hands on. And that was a thrill to have your
Yeah.
fingers in the device and seeing how you can manipulate just the tiniest little things. I think they had something like a piece of paper we were supposed to fold up or something into this little envelope. It was amazing.
Yeah. Yeah, it's a really incredible technology that'll continue to evolve and change while we're practicing physicians to allow us to keep making headway in treating these diseases for patients.
Now, if we're talking about putting diabetes into remission, is there a specific type of bariatric surgery that is more effective than others?
Good question. So, generally, the more intense the operation is, and the more intestine you bypass or skip over, the more intense weight loss you're going to get, and the more intense the changes of those metabolic signals. So, surgery like duodenal switch or single anastomosis, duodenal switch is going to lead to more resolution of diabetes. Um, Bypass will be still excellent amount of resolution, well over 80% for most people. And sleeve gastrectomy, even without skipping over, but getting those effects of weight loss over time, we can see diabetes improve or resolve. That being said, there's also data that shows us that people who have been insulin dependent for more than 5 years have lower rates of resolution.
Okay. Lower rates of resolution of the disease, but they could still theoretically be off of insulin, which is a big deal.
Potential, yeah, off of insulin or a much reduced dose,
Mhm.
better control overall. Um, yeah.
I think my all-time record holder for largest daily insulin dose was a person who was taking U500 concentrated insulin and required something on the order of 1,100 units per day. And I would love to know how a Roux-en-Y or a duodenal switch might change that for him.
I don't have like a number comparison of what you might expect, but I would anticipate, generally we think about duodenal switch with someone with a BMI over 50.
Hmm.
Sometimes it's limited by insurance carriers on when we can offer that. But occasionally we don't have that limitation. And so we can do that, especially for someone with very difficult to control diabetes at a lower BMI. And then we think about how to not skip too much so that they're struggling with protein malnutrition. So the question of what would happen 1,100 units of insulin with a gastric bypass, I would say probably again starting at that kind of half dose or a third of the dose.
Yeah.
That might be someone that I would purposely keep in the hospital an extra day or two so we can really monitor what is that drop in insulin looking like, um, so that we have a better understanding of where to set them up for success when they go home. And then that's definitely someone that I'm going to lean on you as an
Yeah.
endocrinologist to help me. And, whether that patient's seeing me or you every 3 or 4 days, we're looking at those logs and figuring out what's the next best step. That's
Yeah,
actually where
that's
I would
something that I would
pass to you.
consider. Yeah, thank you. Something that I would consider doing a like an insulin drip for, because I would think
Mhm.
that the insulin demand would change so dramatically in such a short period of time. You couldn't hope to really keep up with it with just kind of the usual injection plan.
Yeah.
And you probably would have nursing staff titrating down hour to hour, I would think.
Yeah. I think that's absolutely possible, especially with duodenal switch.
Mhm. So, is it ever a good idea for these patients who have severe diabetes or not, just high BMIs or something, to talk surgery right off the bat, or should everyone try medication first?
I think that depends on the patient. It There are some people who are managing their diabetes well, and I think you and I both see more and more people who have diabetes who are already taking a GLP-1, which is our most effective current medication option for weight loss. And, if they are intolerant to going up on that dose for blood sugar control because of side effects, then we're not going to get additional effects of weight loss with that. So I think it's okay to move to surgical intervention faster. Um, or we may have someone who is newly diabetic who says, I don't want to get to the point I want to be on insulin. So I think it's a patient by patient um, thought process and collaboration with them on what works for them.
I think that's very reasonable. Speaking of these GLPs,
Mm-hmm.
uh, why bother with surgery when we have things like Zepbound that are so effective?
Well, when you look at the Surmount trial for Zepbound or Manjaro or tirzepatide, to use the generic name in the trials, when they looked at the weight loss for non-diabetics, it's about 20% of total body weight loss for about half the people in the trial. And that's incredible. We
Yeah.
haven't had anything that good before. When we look at the weight loss for people with diabetes and obesity, it's about 15%. So we know people with diabetes have less overall weight loss compared to people who do not. And we actually see that in the surgical literature a little bit as well.
Hmm.
People have a little bit lower weight loss when they have diabetes. Um, and to me, that kind of speaks to reasonable to get more aggressive if we're not seeing the results with GLP-1s. The other factor to remember is that many people have a very significant amount of weight they need to lose. So we're talking about people with diabetes and should they have GLP-1s or look at surgery. When we think about the amount of weight loss that somebody might need to lose or that they have a goal in mind for, average weight loss with tirzepatide is about 15%, which is great.
Hmm.
But surgery still outperforms that, where we still see about 25 to 30% with sleeve, 35 to 40% with bypass, and 40% plus with duodenal switch. So, in the right patient, that may be the best option.
Well, it's cost effective too if you're looking in the long term.
Absolutely. I counsel people often that surgery is a tool that travels with you. So if you change jobs or your job changes insurance plans, your surgery is your surgery. You get to keep it. And that means you keep all the potential consequences or side effects. And we are going to be good friends forever so that we can keep up with those things, like vitamin deficiencies, that can crop up over time.
And we know that there's a lot of variability in how people respond to these GLP agents. Some people I call super responders, where you give them this teeny dose and they just start dropping pounds so fast that you're like, whoa, let's slow this down a bit, maybe. And then there's other folks who max out their doses, and by God, they either barely budge or I've even had some gain on these meds. Is the same thing true of the surgeries?
It can be, and it's not always known why that is happening. So, you know, just like GLP-1 medication, when we look at surgery like bypass and duodenal switch, your body actually starts to make more endogenous or internal GLP-1,
Mhm.
and that is part of what drives those insulin changes early on. We don't measure that like we would measure someone's sodium or potassium because it's hard to measure, it's expensive to measure. So, there have been some studies that show that that goes up, but it's not something we measure ahead of time. So, just like medications, we have some people that we would call non-responders or low responders. We don't, unfortunately, have a way to predict who that's going to be.
My
Uh,
thought is kind of the more compensatory processes that a person's metabolism has in place to account for maybe prior ups and downs in their life, the more resistant they tend to be to future losses.
yeah.
Is that true in your experience?
It can be. Most people that come for weight loss surgeries have had two or three episodes in their life where they have had excellent weight loss and then slow weight regain and then weight loss again. It is a little harder every time, but I don't know that that necessarily leads to lower weight loss with surgery unless it's in short order.
Mm.
So for example, someone who's had a sleeve gastrectomy and they've lost a good amount of weight, but maybe their BMI was 50 and now it's 40, and now 2 years later it's 42, and they've decided, I have some reflux. I'd like to lose some more weight. It's only been 2 years, and you do a sleeve to bypass conversion. They may not lose more than a couple more BMI points, and that's because of those compensatory things. Um, the way I tend to explain that to patients is you get punished a little bit for having successful weight loss.
Yeah, oh, that's true.
You
Yeah.
know, your body gets more efficient with the calories you put in,
Hmm.
and you check resting metabolic rates and um, look at that and see those changes drop when people lose weight from any route.
Oh God. Yeah. And I could talk to you in depth ad nauseum about these kind of evolutionary mechanisms that are in place to prevent you from losing, because nature has designed quite a piece of work here, right? And it's going to survive any starvation conditions for as long as possible.
Uh, Absolutely. Our bodies, all of our little cells have not figured out that we have Uber Eats, let alone refrigeration and safe food handling, right? So
So true.
when your calories decrease, all those little cells are like, "Oh, there's less coming in. We better be
Yeah.
better at what we've got.
Yep.
Conserve, conserve."
So, two more questions for you.
Okay.
Number one, I broach the topic of metabolic surgery frequently in diabetes and weight consultations, and I address it as one of many tools that are available to achieve goals. And I almost universally get the response of, well, that seems too extreme. I shouldn't do that. And so I want to know what you say to that, and then who you think would be a good candidate for metabolic surgery to really not maybe resolve or put into remission their diabetes.
Okay, so first question, people who are hesitant or a little timid about surgery. First of all, I think that's normal. You're thinking about doing something that is a permanent change to your body to improve your health. And so you want to know that it's safe. It is. And you want to know what your risks are, which we can show people. We use a calculator that compares people and their weight loss to other people who've already had surgery. So we can look at other coexisting conditions like diabetes and high blood pressure or kidney disease. And we can look at those risks. And there are times when I will tell someone, yeah, this is maybe too high of a risk for you right now. And this is why. So this is what we need to optimize first. Um, as a whole, bariatric surgery now in the United States is as safe as gallbladder surgery,
Oh,
and people
wow.
don't really think twice about that in general.
Yeah,
Uh,
no, you're right.
and there are caveats to that, certainly based on medical history. but it is a safe and effective intervention. Um, you also need to be ready for it. And some people are and some people are not. And one of the nice things about GLP-1s becoming more popular is it's opened up these conversations more
Yes,
broadly. And I bet you see that in your office too, where you get more um, more questions from patients.
well, it used to be that you were trained very specific ways to open the dialogue about weight.
Hmm.
And there are certain words to use and certain words not to use, and how you're going to time the question about you want to lose weight. And I think so many of those barriers are gone now that GLPs and social media, for better or for worse, have really launched this in the public's face. And it's socially acceptable and feasible to just ask and
Finally,
get these solutions.
thank you. Thank you,
Yes.
social media.
Yeah.
Thank you.
The one thing I'm
You
happy
know,
about.
things
Yeah.
you and I have been having these conversations for years with patients, but giving them that internal feeling that it's okay to ask. And even in our offices where we are friendly, we are your advocate and your ally in figuring that out. Um, I do I think it's made it much easier to have that conversation.
For sure. For sure.
And you asked the second question, but I don't remember what it was.
Oh, it was, who would you consider a good candidate for this to really treat diabetes?
Oh, I think bariatric surgery is a great option for anyone who has a BMI over 35 with diabetes. And the international recommendations actually drop that BMI lower into 30 range. And some insurance commercial carriers in the US will follow that, but not all. And I think that's a little bit more nuanced discussion in those lower BMI,
Mhm.
uh, but can certainly be a discussion. And then I think beyond that, the answer is the right patient for weight loss surgery is the person who is interested in it and wants to learn more about it, and then through that process decides that they have the right information, that that is the best intervention for them.
Yeah. Well, this has been so informative. There's so many other topics I would like to talk to you about at length. And what kind of topic would you want to talk about next time?
Well, I think one thing that comes up on with patients for us is that occasionally we do see that resolution or remission of diabetes, and then 8 or 10 years down the road, that A1C is creeping up, or occasionally it's 3 or 4 years.
Mhm.
And sometimes people feel kind of defeated, and I am sending them to you, and I want to know how to guide that discussion so that when they walk into your office, they're ready to continue taking care of themselves and be ready to keep their health up.
Oh, yeah, that's a good one. And I think talking more about nature's specific design for fat preservation is really useful, because once you kind of know what you're made of and know why the body's going to start shifting things the way that it does, it arms you to better
Mhm.
prepare your lifestyle changes, your surgical approach, what have you, to get your best sustainable outcomes.
Yeah.
Um, but this has been wonderful. I really appreciate your time and expertise. I love how you take care of patients. I love being able to collaborate with you, and I look forward to doing more of these in the future.
That sounds great. We love being in your office, both me and my partners. We have a great time, and it's really nice to have an endocrinologist who takes the time with their patients to really understand what they need. And, there's a reason why I'm not an endocrinologist. It is a very complex field. You need to have someone who can take that time. And you can tell the sirens outside.
I
Um,
don't actually hear them.
oh, okay. Well,
Sounds great.
to 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 close out on that, that
being an endocrinologist is such a complex field. Kudos to you for knowing all those pathways and how they feed back and forth into each other. And it's really nice to have this collaboration with you to make sure we're taking the right care of our patients with diabetes.
I love it. I love it. Can't wait for next time. Give
Next
it up
time.
for Dr. Elizabeth Hooper, metabolic surgeon extraordinaire.
Bye, everybody. See ya.